So what I was going to do, my name's Katie Hannon, and I'm the clinical lead for the ICB for children and young people's respiratory care. By trade, I'm a respiratory nurse, and as you're probably all aware that we've got the new asthma guidelines. So I was just going to, it's really informal this, I was just going to do one session every lunchtime this week, and I can run them again if it's popular in the new year. But what I was going to do was just run through this quickly. But if you've got any questions, because I can't see you, just feel free. I'll put the chat up so I can see the chat. Actually, I don't know if I'll be able to see the chat. Oh, yeah, I can. So if you want to put any questions in the chat, if you haven't got a microphone, but if you want to just butt in, then do, because it's really informal and it's just to kind of like see if we're all on the same page with the new asthma guidelines. So that's my email address. So please email me any questions that you've got as well. So this, I don't know if you'll be able to see this, but this is PCRS have done some really good infographics on the new guidelines, and that's quite a very small slide, so I'm not sure if you'll be able to see it. But actually, this is it enlarged a bit. So basically, for the diagnosis of children and young people with asthma, so this is children over the age of 5, if pheno is available, and this is if you're seeing a child who's got a clinical history of asthma, so you've got any you're suspecting that they have asthma, if you've got pheno available, then pheno is the first line kind of like test that you can do. And if that test comes back positive, so if it's over 35 parts per billion in a child, then you can diagnose them with asthma and you don't need to do any other formal tests. So it just makes it a bit simpler that you can get that asthma diagnosis really early on in that child's asthma journey. So we say that it's from 5+ that they can do pheno. We sometimes start it at 4 in secondary care. We use the no breathe pheno machines, but I know that a lot of the PCNs in Frimley have got the NIOX machines. But as long as they've got incentives for children to do, usually children are really keen to, and after, even if they don't get it the first time, we just sometimes it takes us like 5 or 6 attempts for them to actually get pheno, but usually it's a quick and easy test for children to do. If that comes back inconclusive and they've got that clinical history that you're still suspecting asthma, then you can go on to do spirometry, and you can do reversibility with that spirometry if they're obstructed. And then this was actually taken out of the draft guidelines, but they put it back in to do that peak flow variability. So if you haven't got any access to pheno or spirometry, then you can do that 2-week peak flow diary and get that variability. And I've got all of the diagnostics in a minute that I'll go through. And then if all of those are inconclusive, then you can do either skin prick testing on a child. So that's our first line of really allergy testing in children, is to do skin prick testing. And then if not, you can do a blood test to check their eosinophil level. So this is the algorithm from the new guidelines. So you can see that pheno, if it's available to do that first off, then as I said, that kind of like the pink version at the top is just what we've just gone through. And then it goes into obviously your variability, and also your kind of like your levels of how, when you can actually diagnose, when it's a positive result. The highlights this is really a basic overview of the new guidelines, but no one should be on a SABA alone. And I hope that that we're kind of, anyone who's clinically we're suspecting with asthma, that they wouldn't be on a SABA alone. But we can obviously change them. If you did have a patient who you saw who was on a SABA alone, then you can change them, and it is definitely that directive to change them onto an ICS. Under the age of 5 is the only area where there's now a trial of treatment is recommended. So this is the under 5s who we can't do a formal test of asthma. So then we would do a trial of treatments for 8 to 12 weeks, and then actually stop that treatment. And that's really key, is to actually stop that treatment at the end of that trial and see if their symptoms do reoccur. There's two pathways for the 5 to 11-year-olds. So the first one is really to consider MART in this age group. So the inhalers are now licensed for children over the age of 5 for MART, but we've only got a very few number of those inhalers that we can use with MART in this age group. But MART is currently off-label in this age group, but they have included it in the guidelines, so you can follow guidelines and actually start children over the age of 5 onto a MART regime. There is a conventional pathway available. So and again, this is due to your clinical judgment. So if you see a child, I would be very cautious in a child aged 5 to start a MART regime, personally, as a paediatric nurse, but because they would go onto a dry powdered inhaler, but usually, but actually, which that is licensed in children over the age of 5, but just really to make sure that if you see any children, to make sure that they are actually able to take that inhaler. So we tend to change children over onto a MART dry powdered inhaler regime probably around the age of 7 or 8, and we would change them. And on Healthier Together, we've got lots of videos on how we change them over in clinic safely onto that new regime. So, but if you're at all worried that they're not going to be able to cope with that new inhaler, then obviously the best inhaler is the one that they're going to be able to take. So use that conventional pathway in asthma management if they can't use MART. But definitely MART comes into its own, especially in this age group, as soon as they're getting more towards the latter years of primary school, going on to secondary school, and it's a really good way of them being able to control their own asthma and also carry their inhalers around with them by themselves, which they obviously do as soon as they get to secondary school. So this is the pharmacological management of children aged 5 to 11. These all I can put links to these in the chat so you can find them, but they're all really accessible within the new nice BTS sign guidelines. So I don't know if you can see that. It might be a bit small for you. Let me see if I can get it bigger. I might be able to. Oh, no, it's not letting me. Oh no, just change slides. That's not very good, isn't it? So I have got my glasses on, but I still struggle to read this because it's so small on my screen as well. Let me see. Oh no, I don't want to turn that on. That's not a good idea. I'm just seeing if I could make it look bigger. Oh, magnify slide for all. That looks good. Oh, still not working though. Sorry. I don't know if you can read that, but anyway, they are really accessible, and I will put the links in the chat. Oh, Michelle's sending a message through. Anyway, I hope that you can read it better on your screen. Yeah, sorry, the cough pathway. So Michelle's asked in the chat, any idea when it will change on the cough pathway? And I'm pretty sure it will be April when they change cough again. I know that we had a meeting with NHS England, and they know that obviously the cough guidance is slightly out of sync now, because I think the cough guidance does say that obviously spirometry is your first kind of like line of formal testing with children. So it will change, but it hasn't changed yet. But these are the new guidelines for us to follow. So hopefully April that will change as well. So everything will be in line. And actually our paediatric formulary, I don't know if Noreen's on the call, but they're looking to change our paediatric formulary so that MART is actually included in the children aged 5+ as well. Yeah. Also, it might be June, July that the cough is updated, but it is in hand to update alongside these guidelines. So going back to the algorithm D, so this is for children aged 5 to 11, and really you can see that the kind of like big push now is onto that MART. So if you've got a newly diagnosed child in front of you, then definitely if they're over the age of around 7, I mean, you can try it from the age of 5, but I don't know what you use in clinic. When we change children over to a dry powder device, from the age of in clinic, we tend to use the in-check dial. So I don't know if any of you have got access to in-check dials to check that they've got enough inspiratory strength to actually use that dry powdered inhaler. I think in-check dials you can get, they're around £30 each. They're usually from Clark Clements, and I'm not sure if there's any others kind of like companies who make the in-check dial, or you can go to, if you're going to use Symbicort, then go to AstraZeneca and get the whistles, just to make sure that child can make that, obviously, has got the strength to use that dry powdered inhaler. And when we're starting children on dry powdered inhalers, we literally take away, if they're already a diagnosed asthmatic, we do say to them that they don't need to use their blue inhaler at all anymore. Then they just use that for everything, for their symptom relief and also their reliever. So it's and we have put a video on Healthier Together on how you do that in children, but this will be your bread and butter, so you'll be used to this. So that's in the children aged 5 to 11. So if they can't go on to MART, then put them on that conventional asthma and ICS, and also a SABA, that conventional ABBA, kind of like asthma ABBA. I don't know where that's come from. Algorithm C, you've got children over 12 years and over. So really now, I mean, and this is, I think, brilliant for children over the age of 12 years. But if you've got a child who is hasn't been diagnosed as asthma before, then you can start them on an air regime, which was never which is just in the guidelines now for children over the age of 12, and then obviously go to low dose MART if their asthma is not controlled, and then moderate dose MART. And I've got actually the pediatric formulary if you wanted us to go through quickly. Let's have a look. I'll go through back to so this is the pediatric formulary for ages 12 to 17 years. So obviously we've got Symbicort, which is the only one that is on there at the moment for MART, but there are a couple of other inhalers that are now licensed for this age group. So it's really dependent on what you feel that child will use, and obviously the best asthma regime is the one that they're going to take. So we now change over anyone who's in front of us in clinic. So if they've got any, if you're seeing a patient, like we do phenos all the time, and like even a couple of weeks ago we had a child in who had just had an asthma attack, so had been seen in secondary care, so that's why I came to our paediatric asthma clinic, and his pheno was 170 parts per billion. So this was 4 weeks post having an asthma attack, so he'd already been treated with dexamethasone in hospital. So came into us, his pheno was really high, but still not really saying, and this is what we see in asthma all the time with children, still not really saying that he had many asthma symptoms. So we started him, well, he had already been started on Symbicort post having his asthma attack, but just went through, he wasn't taking it properly. So went through his adherence, that he needed to take it twice a day, as well as when he had symptoms, and also what those symptoms would look like. And then actually the next time we saw him, which was a couple of weeks ago, his pheno was down to 76. So, a really big improvement. And actually just talking to that family, like his dad and himself, like initially he was saying that he didn't really have any asthma symptoms when I saw him previously, and his pheno was 170, but actually he said that he did feel much better. And that's what we see in children, that they just get used to feeling symptomatic, so that is just part of how they feel, so they don't realize how unwell they feel. And you must see this with your patients, until you actually start that treatment off effectively and you can watch that pheno go down. And this is why we really like pheno in secondary care, because it's getting those parents to understand that number as well. And we always explain it to children that it's kind of like that underneath part of the iceberg, that they may, that is showing us how much inflammation they have in their airways. So That's really Symbicort's on the primary care formulary at the moment for you to change anyone over to. I know that this will change and be updated as well in due course. The only we have got Symbicort on the primary care formulary for children aged 5 to 12 years. And obviously, MART is now a part of the new guidelines for this age group. So Symbicort can be used, but it's not as part of a MART regime because MART regimes were never for this age group. So now that they are, this will be changed. And although it's off label, it is, you are able to use it because it is part of the new guidance. Let me see. This is part of the PCRS. I'll put a link to this and send you a link to this because I really like this infographics. I like the way that they've gone through it. And this is obviously lots of different information on the new guidance and how to implement it into practice. Let me see what else I put. Oh, that's it. Yeah. So I'm going to stop sharing. And if you've got any questions or anything you want to talk about, then please talk now. I don't mind if you don't raise your hands and if you just chat.
May I please ask, is there formal training for we've got a NIOX machine,
Okay.
but I've gone onto their website and had a look at the stuff on there because when I started here, our machine was broken. It needed a new sensor. So I've just done the training, which I assume is okay, on the NIOX website. I don't know if there's anything else more formal I need to do for.
No, I mean, there is training on e-learning for health. So you know where the e-learning for health website is. There is free pheno training that you can do on there as well. I don't know if you've had a look at that.
I think I had a look at it, and then we waited so long for a decision over whether we were getting another sensor or not that I then gave up because I was like, by the time we get to the choice where we've had another sensor, I'd have probably forgotten by then. So I can go back to the e-learning for health. So I've got a colleague who needs to do it as well. So.
Oh, okay, that's brilliant. Well, you'll get a certificate and everything doing the e-learning for health. So it's I suppose it's a bit more formal than just the guidance from the manufacturer.
Real.
Can you just because I mean this is what obviously I know that all of the LCS includes children from the age of 5, so you will get money back for any tests that you do on children over the age of 5. But could you just, if you could, put in the chat whether or not you do pheno on children? I have got an audit that I've got to send round to all the PCN managers, but it's just really interesting to see. I did an audit, I think it was at the beginning of last year, and only 5 surgeries came back to say that they did do pheno. So I'm just wondering, because I know that there's been a lot of work with pheno, hasn't there, in that 12-month period. So I'm hoping that more surgeries have got access. But Michelle, it's interesting what you said about the filter, because I think that's the issue, isn't it, with the NIOX machine, is that the filters are quite expensive, aren't they?
It was extortionately expensive. It was like nearly £1,000, and it only lasts so many breaths. And I think that was the longest decision that they had to make over spending the money. I think there was something along the lines of, was there going to be a central hub for doing them, etc., etc. But it's that specific part, I believe. It's just looks like just a little plug that you stick in the back, but it was expensive.
I know. I'm because we don't use NIOX in secondary care. We use the no breathe machines, and it doesn't seem to have that issue with the filter because the filters are included in the mouthpieces. So you just, you obviously give one mouthpiece because I think ideally you're meant to do 3 pheno. You're meant to get an average. I mean, all our machines are really they have been really, I mean, they're obviously tested every year and things like that. They go through their quality tests, but they do seem to give really accurate results. But they do say to use it 3 times to get a result. So I don't know if that's the same with the NIOX, but if it's per breath, then that's even going to be less patients, isn't it?
Yeah, that's what I was like
Yeah.
thinking, like if you're sort of trying to practice to have a go and get used to using it a bit more. But then if it's
Yes.
you can use the mouthpiece that you change. Obviously, it's got the disposable mouthpiece, but then there's a sensor that actually fits in the machine, and that's the bit that needed replacing. That I think was
Yeah.
the money
That's
maker.
yeah, I know. That's a really expensive bit, isn't it?
Mm.
That's yeah, I mean, like I'm not used to the Niox machines, but I know that obviously that's the issue, is that you know, they're costing a lot to get up and running. I mean, I think that most people are doing it. Looks like on the chat that most people are doing Pheno and Spiral on children, which is brilliant. And I think that maybe even moving forward, I mean, we've always had that big push. I mean, spirometry is great, isn't it? And we still do spirometry, but you know, maybe in the future we'll have less of a focus on spirometry and more of a focus on Pheno, and only doing spirometry on the children where we get a inconclusive Pheno. So I don't know, you know, if that's going to be the. We are doing work to do the CDCs. So we've just won a bid for a CDC children and young people's asthma pathway. So it kind of puts children and young people on the map for the diagnostic hubs, which is good. And getting children to be seen in the diagnostic hubs. But as I say, that's not up and running yet. And so ideally, I think there's, you know, in the future is that these diagnostic hubs would run alongside primary care, you know, so it wouldn't take Pheno away from primary care, but it would just give more, you know, we could go on to different tests or do spirometry in the diagnostic hubs, or just do it alongside whatever they're getting in primary care as well. But we don't want to double commission a service, obviously. So that's things that we're looking at the moment. Um, any other questions about the guidelines? I don't know if any of you have managed to implement any of them yet. Or are you changing children over onto a dry powdered inhalers or a MART regime if you're seeing children in clinic? Jennifer's writing something. Got my three little dots. I don't know if anyone has managed to implement any of the new guidance yet. Or anything that you want me to do. I mean, because obviously I was going to run these every lunchtime this week. And did you want me to go through a case study, or what kind of parts of the guidance would you? And Noreen's going to log on to one of them as well. So she's the medicines management. Yeah, I mean, like Mark is your. I mean, for pediatrics, we were really excited when Mark came in, but this is something that you've been doing for so long, haven't you, in adult care? So I mean, like, you are really the experts, and it's just the one thing that, like, we just to make sure that if you change the child over onto that dry powdered inhaler, that we've got an issue with asthma friendly schools will often have the blue inhaler. So what we're saying to children and to families, that if you change them onto a MART regime, they can still use that emergency inhaler that they may have at school, you know, that the school may have. They can still use that blue inhaler, but we do take away all of the other blue inhalers from the child and say that they don't need them anymore. And we just give them that, you know, that mark kind of like guidance for when they're having an asthma attack. But yeah, I think that you're going to be the experts with MART, so you're not going to worry so much about changing children onto MART. So who's this? Jennifer. It's hard as there's no pressurized device with MART licensed. And as you know, most younger children don't have the ability for a DPI, but we are reviewing all children who are already on Symbicort. Oh, brilliant. So we do I mean, Symbicort is the one that we've been changing all of our children onto, and we obviously use that in-check dial. And what we found with the in-check dial is, well, we've only found one child who didn't have enough inspiratory strength to use the dry powdered inhaler, actually, surprisingly. Um, so I don't think they do need a lot of strength. It's just that getting them to use it and to understand that they need to suck, and all the rest of it, and actually just hold their breath afterwards. But we use the Asthma and Lung UK video that's on there, and we just get them to watch that. We give them little demo Symbicort inhalers to practice with, and then we haven't got the whistles just because they're a lot of plastic that then we seem to be giving out to patients. But if you haven't got an in-check dial, then the whistles are fine. We just did that more of as an environmental kind of like thing, not to use the whistles. But it's just making sure that that child has enough inspiratory strength, and also then just following them up to make sure that they're happy with obviously their inhaler, which you would do anyway. And I think that is it, isn't it? It's now past, so I'm conscious that this is your lunchtime, so I don't want to keep you, or it's now 28 minutes past, so I've got 2 minutes for any more questions. Um, I know that some of you, your microphones are not working, but if not, no questions, then you've got probably 1 minute, by the 1 minute extra to do. Oh, Gemma's putting a question in the. Oh no, hold on. Oh, sorry, Claire, I didn't see your question. So Claire said, is there anything particular we would need to know regarding changes for children in the emergency department? So I suppose that the emergency department, they just got to be educated on Symbicort, isn't it? Because we know that obviously children will be turning up with their Symbicort rather than actually their Saba, their blue Saba inhaler. So that will be a piece of work that we'll do with the secondary care team to really get that message across. And maybe that's something that I'll talk to Nina, who's the lead for the asthma team in secondary care, to see what we need to give ED. So good question. Thank you. Oh, good. No, but anything you want, just send me an email anyway. But I'll be here tomorrow as well if you've got any other questions that you think of. Anyway, nice to see you all, and take care, and thanks for dropping in.